We have a trial that's Champion Phoenix that you've all heard of and probably read the original results from. There's a new analysis that's really interesting, and we're at the TCT meeting, and I'm talking to Philippe Genereux. Now, I got to tell you that this is great because he's the director of the Angiographic Core Laboratory at the Cardiovascular Research Foundation, CRF. This is actually your meeting, the TCT meeting, so thank you twice. Thanks for doing the interview, and thanks for the great meeting.
It's my pleasure. Thank you.
Now, the Champion Phoenix trial is a classic trial. Can you remind us what it's about, the original trial?
Sure, absolutely. So Deepak, back in the leadership of Champion Phoenix, presented a trial at ACC last year, mainly showing among the population of more than 10,000 patients undergoing PCI that cangrelor compared to clopidogrel, given at the time of the PCI, decreased the primary efficacy endpoint of composite endpoint of death, MI, ischemic-driven revascularization, and stent thrombosis. Also decreased the pre-specified secondary endpoint of stent thrombosis, mainly establishing the superiority of cangrelor at the time, given at the time of the PCI. That was the main finding of the Champion Phoenix.
Now, coming up in JACC, we have the paper that you're presenting data here at TCT, and it's the impact of intra-procedural stent thrombosis, or IPST, during PCI. This is insights from the Champion Phoenix trial. So what were you looking at specifically this time around?
So like we said just prior, the secondary endpoint was the stent thrombosis. The particularity of Champion Phoenix was that the stent thrombosis was defined mainly at 48 hours by the combination of ARC stent thrombosis, definite probable, right, but also in addition a relatively new endpoint of intra-procedural stent thrombosis. So compared to the well-known outside the lab ARC stent thrombosis, we had also what we call IPST, the intra-procedural stent thrombosis. And actually the difference in the secondary endpoint was mainly driven by this new IPST outcome. So what we seek to do actually is to show what was, first of all, the predictor of IPST in Champion Phoenix, but also what was the impact of this relatively new endpoint.
Now, with 11,000, almost 11,000 people to analyze, what did you find?
So that's good that you mentioned it. So almost 11,000 patients, so mainly the largest angiographic analysis ever performed. And the main finding actually is IPST occurring inside the cath lab during the procedure actually was bad. Mainly was predictor of 48 hours death, mainly predictor also of 48 hours and 30 days stent thrombosis. So increasing the rate of death by 20-fold in the whole population, and increasing the risk of stent thrombosis mainly by 10 times. IPST was a relatively rare event, 1% in the old group, the old cohort, but we have to put things in perspective, because when we compare to the definite stent thrombosis, which is 0.3%, I think IPST is, like you see, 3 times more frequent than stent thrombosis. One finding interesting also is that cangrelor compared to clopidogrel decreased significantly the rate of IPST. And one point important actually is the decrease and the benefit of cangrelor was sustained across all the subgroup, including stable angina, non-STEMI, and STEMI patient. So clearly, this study will establish the bad outcome associated with IPST, but also the superiority of cangrelor compared to clopidogrel to reduce this outcome.
What's the mechanism that explains the outcome?
So that's a very good question, actually. To put things in context, when you do a procedure, the formation of a new clot inside a stent is seen as something concerning. Even when we resolve the new clot, the outcome was worse. So we don't understand really what is the mechanism why intra-procedural stent thrombosis is associated with a bad outcome. But what we know is it was associated with a 20-time increase in death and future stent thrombosis outside the lab. So, of course, one of the mechanisms is potentially leading to distal embolization, endothelial dysfunction, and potentially also occurring on patients that are at higher risk compared, or maybe sicker than patients that do not have IPST. So a lot of work to do to understand better this mechanism, but one thing is sure is given the bad prognosis of this IPST, I think we need to focus to reduce this complication.
Now, the fact that there is a clinical benefit in this trial, what would you say is the clinical take-home message of Champion Phoenix in this analysis?
So I think we still stay in line with the main message of Champion Phoenix that has been published, showing the superiority of Cangrelor compared to clopidogrel at the time of the PCI. From our analysis, actually, I think we are in a state in 2013 where we need to continue to improve outcome inside the lab, and clearly the decrease, the decrease of IPST is one of these steps where we need to make sure that the PCI is performed safely and that we will be able to decrease the occurrence of this complication. And I think the choice of the selection of the best antithrombotic agent is part of this improvement of outcome in PCI. And I think with this analysis of and Champion Phoenix, we show once again that Cangrelor was superior to clopidogrel to reduce IPST. So I think that's the main message.
And the intra-procedural stent thrombosis was in a fairly predictable group of people, high risk, STEMI or non-STEMI, correct?
Yes, exactly. So the predictive factor of IPST was mainly, and it's not surprising actually, a patient with a lot of thrombus at baseline, right, patient with STEMI, patient with non-STEMI, but also it's interesting when we implant a long stent. So I think there's clearly an interaction between the patient characteristic at baseline, the lesion characteristic, but also the type of intervention we're doing, which call for better antithrombotic treatment, but also better platform and most likely better technique of implantation.
Well, intraprocedural stent thrombosis, IPST, is something you're going to hear more about. And to read about it in JACC, it's going to be published online, concurrent with the presentation here at TCT by Dr. Genereux, who is the first author. For CardioSource World News, I'm Rick McGuire.